So we are on week 9. It's going by really quick. We are almost to week 10, which is your third exam. This week we will be doing our exam reviews. I do mine tomorrow at 3 o'clock. I try to do it earlier in the week because many of you like to see it earlier and then go to someone else's as that refresh to my review, which is fine. Whichever way it works for you, that is good. You do have another case study due, a discussion question due, and we do have dosage calculations that's due. And they're all, the case study and dosage calc are over a point each. So make sure you do get those in for your homework grades. So today we're going to do two things, two chapters. We're going to do musculoskeletal and neuromuscular. And the way I do class is I'm going to give you a PowerPoint. We're going to discuss one of the chapters, and then we're going to stop. And then we're going to do a Kahoot on that chapter. So you're instantly tested with that information. And then I'm going to do the second chapter followed by the Kahoot. So you all from the other class, don't worry, you're all going to get my recording. You're going to get the Kahoots. I'm going to send you the PowerPoint. Whatever else you need, let me know, and I can send it to you. It's not a problem at all. My stuff is your stuff. I make it for you, not for me. So let's go ahead. Any questions, anybody? Okay. So let's start with our PowerPoint for today. So let's start with musculoskeletal articular dysfunction. This is when the bones, the joints are not, they're broken, they're strained, they're sprained, they're all different sort of things. I think this pictures up here are showing you many, many different problems with muscles or bone articulation. The top left one, that little baby, is where the hip joint doesn't get into the hip socket. That's a Pavlik harness. You need to know that. That's an abduction to make it go back into place. Of course, we have casts. You need to learn how to take care of them. Crutches, you've learned that, foundations, how to use them. The bottom left is a spica cast. That happens a lot with myelomeningocele and has to do with that bone and the spine. And then the bottom right one is something we called Buck's traction. It's called skin traction. It's nothing that goes in a bone. It's this boot that's sort of strapped to the lower leg and it pulls it. And it pulls the femur bone out. So it's not, when it's broken, we could put the edges back together so it doesn't hurt because there's little splinters and little sharp edges that go into muscles and nerves and hurt. So that Buck's traction straightens it out. So let's go into a lot of this stuff now. So a mobilized child. We've got a child and we're thinking kids are up and out and moving and nobody's immobilized. Well, I wish, but there are children that have congenital or degenerative disorders that they're never able to be up and out and moving and walking normally, okay? And we have to work with that. What our goal as nurses is to do therapies that can make them be mobile as long as they can. Okay, we don't want things that keep them, for instance, you would do physical therapy on a patient on bed rest to prevent foot drop, right? Preventing muscle contractions, all of these things. We have some children that will be in bed a long period of time and they can be moved in physical therapy. There actually is one of them that I would say no physical therapy, and that diagnosis is called osteogenesis imperfecta. It's brittle bones. We're going to go into that in a little bit. So, things that happen when you are immobile. Well, we know your muscle strength goes down. That's the foot drop and muscle weakness and all of those things. We know the bones don't get all the minerals and all the exercise they need. So, we've got problems with that. And then I think the thing that we think of most when we think of bed rest is that DVTs and problems with lungs getting congested, right? That, stasis, dependent edema. And we need to try to prevent that. How do we prevent those effects of immobilization on the cardiovascular system? It's as simple as turning, positioning, rubbing them, inspecting the skin, and then if they're alert and awake, maybe doing respiratory treatments, exercising, wiggling toes. All of these things can help. Now, what if you were that kid on completely immobile, can't get up, can't get out? I mean, that might be your only view is staring out the window all day long, right? And if I was a young kid, I'd be very depressed if that was me. Many of these children end up depressed because look at their environment, right? We need to do something to help it. And they get angry and they get very aggressive. And I don't blame them because we need to do something to help them understand their environment and to work with it. Now, it's not just the kid who's having an issue. Just think about the entire family. It's the brothers, the sisters, it could be their nieces and nephews, could be cousins. I mean, it really does affect when you have a child that's not at home, that's in the hospital. Think about it. Another kid needs to have a parent go to kids' day or parents' day at school. Are they at the hospital? Or are they taking care of the other kid? So the other child has to be aware of these things. So we really need to support those family because of those things. A lot of times I have seen, especially in the pediatric facility where I worked, every single floor had a different diagnosis, whether it was GI, whether it was neuro, whether it was cardiac, and they had family groups and they met these parent groups every month. And sometimes they even brought in siblings because they got to discuss how they felt, what was going on. And it really does help these parent groups. All right, let's get into what is these sort of injuries kids do. Well, we know kids, they don't know how to warm up and stretch. They get up and go and run out the door and they're ready to go. So they do have a lot of injuries to soft tissues, muscles, ligaments, and tendons. It's just part of what happens. Part of it's just the normal falling down, the normal injuries, but some is, again, they're not stretching and getting ready to go out and play. Now, bruising, contusions, not a big deal, right? Well, you got to be careful. Sometimes when we have some ecchymotic that we show on the outside of the skin, think about how deep that blood that has escaped into the tissue is gone. Sometimes it can occlude circulation. So always, you see a crush injury, you see an ecchymotic area, always check distally. So if I saw a crush area on the upper arm, I'm going to be checking pulses and capillary refill of my arm, my finger, my hand, right? Radial pulse, ulnar pulse, are they ever all there? These are things that I'm going to be checking. So you're going to hear throughout this, neurovascular signs are very important. So dislocations, this happens. I think the biggest one I've seen is what we call a nursemaid elbow, and it's not written on this slide. And what it is you have these little children, toddlers, ages 2 to 3 years old, and their tendons and ligaments are very soft and flexible. And we as adults like to pick them up by their arms, and we like to shake them and move them around, and the kid likes it. Well, the elbow gets out of joint and then it's stretched and it can't be bent. That's called a nursemaid elbow. It hurts while it's out of joint. But what do? We don't even do an x-ray on this. We see an arm hanging to the side. The practitioner, the PA, the doctor, not a nurse, all the other people can take and just they twist the arm carefully and it pops it into joint and we put a little sling on their arm and they're sent home with it and telling the parents, please no more swinging by the arms. That is a dislocation. Another one that we do see a lot is our poor little Downs children. We have hypothyroidism, we have leukemia, we have cardiac disease. Oh, and now we have hip dislocations. Ever see a Downs child? They can take both feet and put them behind their head. That can pop their hips out of joint. The problem is it could disrupt the blood supply. So we should not encourage that. Now, sprains and strains, I think a sprain and strain are more painful than any fracture. I can't even tell you how many sprains I had. I had six brothers, so I was a real sports person through high school and through college. I was always spraining one ankle or the other one. And as soon as it gets sprained, you could feel it start to swell, and the pain was intense. Okay. So sprains is that torn or stretched ligament, and it does hurt. It usually stretches and it stretches blood supply. That's why that's swelling. Also, blood's flowing in there. And you can see this rapid onset of swelling. I know playing volleyball, going up, spiking a ball, coming down, twisting my ankle. First thing I'm going to do is stick my ankle straight up in the air because I know it's going to start swelling. And then, of course, what happens? Here comes my coach with an ice bag. We're going to ace it up and we're going to take care of it. Okay. And we're going to go into all the things we need to do for sprains or strains. Now, a strain is just when you use some muscle group over and over again. I think we see this a lot with Olympics, right? Where we're using whether our knees, our ankles, our hips, or whatever. This is something that's used over and over again, and it causes these little microscopic tears, and it does cause pain because of the overuse. Now, this is how we treat it. I told you, I took my foot, put it straight up in the air when I sprain it. And I'm telling you, I did it at least once every season in any sport. I mean, I was always, something with a sprain on an ankle. So immediately, what did I do? I sat down and put it up in the air. So it's rices and ices. First, rest, ice it. It constricts that blood vessel that wants to put all that blood in that joint and the area and cause swelling and pain. And then we're going to put that ACE bandage on it so that we compress it. It's like putting a finger on something that's bleeding. It stops the bleeding. And then, of course, we're going to elevate it, put it in the air. If it's above the heart, it's not going to get the blood up there as much. And then I'll even say this above that: calm the child down. Decrease the heart rate is going to decrease bleeding too, right? Years ago, sprains, we put an ACE bandage on or an ACE wrap on the ankle type thing, and we didn't put a lot of cast on them. Today, we've realized that putting then a little immobilized support, whether it's a splint or a cast, even if it's not broken, is actually the best way to treat them so that we immobilize the area that was injured. Now, fractures. Kids fall down all the time. Absolutely common. Realize that infants, it's not common for them to get fractures. And if we see a fracture in an infant, we need to really look at it very, very closely. Okay. I've seen an infant that actually had a fractured skull. And I took this child into the triage area. I picked it up out of the mother's arm, underneath the head and the shoulder and the neck, and underneath the buttocks. And I picked that child up out of the mother. And when I touched the back of the head with this arm, and it was very gentle, the kid cried. And I was like, ooh. And I could feel like the bone felt flexible. And I went, this isn't good. So I did my assessment, brought the child to the back. I notified the charge nurse and I notified the attending physician of my suspicions. This child was abused. This child, this 3-month-old infant, not only had a fractured skull, also had a fractured humerus, fractured ribs, and a fractured femur. Okay? This is just, I felt something, didn't feel right, it needed investigation. When you talk about child abuse, when the injuries don't match what you're seeing, you need to suspect it. It's better to be safe than sorry. Kids can't protect themselves. That's what we're here for if they're in our care, okay? We know what's the most common of all of the breaks. They fall down, you put your hands out. So it's radial ulna, one or both. And it could be even bilateral. I've seen bilateral, both of the bones can come too. And we know when we get to children and bikes and sports, they're going to be injured. So let's look at the type of fractures now. I think the most common that we see is what we call a simple or closed. For instance, they fall down, they're on their wrist, and we see pain and swelling in the wrist. Okay? We know that there's no bone sticking out, but we see it swollen. We know that there's something there going on. Do an x-ray. And then we could put a cast on if it needs. Now, sometimes the bone comes out. Here's a picture of an elbow that comes out, but it could be a knee, could be an ankle, could be anything where the bone comes out of the skin. Well, once a bone comes out of the skin, it's into the environment. And now our concern is going to be infection. Infection. That's our big thing. Open or compound, our biggest thing is infection. So, priority is antibiotics. As long as we got good neurovascular signs, blood flow's going good, okay, start the antibiotics first. And then also, we're going to be monitoring this child's temperature because our chances for infections are great. So we need to be constantly monitoring that to see, make sure, is that child still without a temperature? That means the antibiotics that we're giving that child is working. We have something called complicated. I think the ones rib fractures that go into the lungs and penetrate the lungs and cause pneumothorax. Complicated. I think that's the one I like to use there. Comminuted. They break the bones and they splinter. So they got all these pieces in the skin and they're extremely painful. And then something called an avulsion. The bone and the tendons rip from each other. So now it's this swelling, it's this pain, and it's really, really painful. That's called an avulsion. Now, the big, big problem with children and getting a broken bone is that they're still growing. And we still want the fingers, the legs, the arms. We want them all growing at the same rate on both sides. So we don't have a short leg, a short finger, a short toe, anything. So growth plate injuries are our big deal. And we could see it there at the end of the bone. I think the biggest growth plate injury I see is the elbow. And if it's that elbow and that growth plate, they're going to go for surgery. Because if we fractured the bone on the growth plate, it will shift. So now you might have a growing crooked bone. So you have to do open reduction, internal fixation to approximate and line that bone up perfectly so that the bone still grows at the same rate and it is not crooked. Does that make sense to you? Biggest concern is growth plate injuries in children. We need them fixed properly. Now, kids, infants, neonates, that's the first 28 days of life. They can heal a bone in 2 to 3 weeks. Isn't that amazing? How quickly? But me, I'm 8 to 12 or 12 to 28 weeks. I mean, as you get older, it's a longer amount of time that your body needs to heal. Now, why do I really stress that neonatal period? Well, if they come out, let's say with club feet, if I do the right thing, by the time that they're 28 days old, if we do it right away, quick, we can have those club feet on the right way, men coming back, don't we? So you get a child, fractured bone. What do you need to do? Well, you need an x-ray. You need to prove, is the bone fractured? I want you to know that every child that I have done any sort of bone, anything with them, I always let them look at the bone. I think a child, 2, 3 years old, even, show them this is where the break is and tell them what they need to do to make it all better, the boo boo all better. You show them that it's broke. And now they understand, don't get the cast wet. Why does it hurt? That we need to keep it elevated, to ask mommy for something for pain. These are things that we can teach there, right? So, x-ray, show it to them. One of the things that we see in children is if they're not putting weight on a leg and ankle or something, we know it's broke because they will touch it if it's sprained. They will not put any weight on it if it is broke. So goal, what is our goal in any fracture? We want to reduce and immobilize it. We want the function to be maintained, and we don't want a deformity. So all of the things that we do are to make sure that bone is straight. So I took some very bizarre type of healing things. But these are two pictures of a child who had a cast on, who went into compartmental syndrome because nobody noticed, or they sent home and nobody told the parents about it. And now they come back with either a necrotic arm and hand or one that's getting there. Okay. So, what do we need to do? And what do we need to teach our children and our parents, our caregivers? And it's the 6 P's. I want to know the pain, the point of tenderness. Is it increasing? Pallor. Is it pink or is it pale? Pale means no blood flow. Pulselessness. No pulses, no blood flow. Paresthesia, no blood flow. Paralysis, again, no blood flow going there. And it's all this pressure going on. So 6 P's, very important with fractures. You do the rice when you get it. And now after you get the cast on, you teach the 6 P's. So casting and cast care. In pediatrics, I was really blessed that I worked in a pediatric facility that had all different color casting type of things. I mean, this little girl, I guess she likes the watermelon, right? Pink and green, but not just she likes it for her spica type cast, but even her doll gets them. And that's not uncommon what we do for children. I think we use like red for Halloween, red and green for Christmas. I mean, orange and black for Halloween. I mean, there's all different sort of colors that we use. And, it's a distraction that kids like, okay, I've got this cool color, my teens colors, on my cast. So I'm really cool now. It's not, well, I got a cast now. This is going on with me. As I said, care management. We need to keep it dry. We need to teach them how to take a shower, take a bath, how to clean this child, and what to do for that cast. Cast care, very important. Remember, and you've done a discussion question, nothing inside. Use a cool hair dryer. That little breeze, actually, that helps with itches that go down there. We like to put hangers in there and scratch. No, all it does is create abrasions and can cause a really bad infection. So I've already mentioned that good old Bucks traction, right? Bucks traction is there's skeletal and there's skin traction. Today we don't use skeletal as much as skin traction. We used to take a pin and put it through their leg and it would pull their femur straight and they would be in a hospital for a month. We don't do that anymore. What we do is we put them in this Bucks traction. It straightens out and it stops the spasms that are happening and all that little size of that sharp broken bone getting to the nerves and muscles and creating pain, and it stretches it out. Then they do surgery. Usually, the next day or next 2 days they'll do it, and they put a rod down that femur bone, and that's all they do now in physical therapy and send them home. Okay, that's more what we do for them. But Bucks traction is great. It's skin traction. It is used to approximate the edges so that we can prevent deformities and then start the healing process. Then they could do the surgery and do the recovery from there. So the purpose of types of traction. Now that upper left one is these thongs. It's actually used for cervical traction. I actually used that one for a little 15-year-old boy who had an angulated C5, C6 fracture, which means there was like a triangle in his upper spine, and he had paralysis of his lower legs. Right leg couldn't feel anything. Left leg, he could sort of move it slightly. Okay, so we put him in tongs overnight, cooled him down, sent him to the OR, did an open reduction, internal fixation of that spine. And I want you to know, a year later, that boy came into the ER to give me a hug. He was doing well. He had absolutely no sort of paralysis or any sort of weakness following it because he was treated and was treated properly. So traction works, and it does work well. And it gives you that moment where there's no pain because those bones going into muscles and nerves hurt. So it stretches it out, stops that pain, and gives you a chance to do that surgery. So we've talked about Buck's traction. That's the upper right. And then you could see there's another one similar to it called Russell's traction. It's just another piece of thing that holds up where the femur is. Which one's better? It's a physician choice. Just know that they're both skin traction. Those weights need to hang 24 hours a day. Do not touch them. Because if you take that weight off, those bones will go like this. And guess what? That kid's going to be screaming in pain. So leave that weight there, free hanging. That kid can't get out of bed. It's 24 hours bed rest. And what is our job? Checking neurovascular signs, making sure the toes are still pink, still movable, still pulses down there. And if we don't feel a pulse and we see little pale little toes, we're calling the doctor immediately. There's something wrong with blood flow. Now, another one that we have is something called Bryant's traction. That's the bottom picture. Now, I mentioned very quickly the Pavlik harness for hip dysplasia, which means the hip joint, the femur head, and the hip, it's not into where it should be. It's up here somewhere. Okay? And we need to get that back into here. So we can use a Pavlik harness. Most of the time it works. But sometimes we need to do something else. And if as they're getting bigger, Pavlik harness, they're too big to be that to work. So we put them in Bryant's traction. Now, Bryant's traction is a right angle with the buttocks slightly off the bed. And you can't weigh more than 30 pounds. And that's the second way that we do to treat your hip dysplasia. Another thing we have is something called distraction. This is something that I've used actually for children with a horrible break, that there's so many pieces, we've just got to do something to approximate and hold these pieces in a certain place. I've also used this for children who have a short leg or a short arm, they want it bigger. They can break it, put this external fixation device on, and the bone is going to make new bone in the in-between. They can be taller. Actually, I had this is funny, but my general practitioner, my internist, at the age of 50, decided he wanted to be taller and did 2 inches on both legs. He told me it was horrible. It was extremely painful. So again, knowing that information, how are we going to treat this child? Make sure that they have plenty of pain control. Now, kids can be born without body parts, fingers, arms, legs, anything, right? One of the things that they can be born out is a leg. Again, the thing is to try to get that kid as mobile as possible, getting a prosthesis on there, right? I've seen children born with only one of the bones. You're supposed to have a tibia and a fibula. They had no fibula. So they had to do an amputation because there's no way to stick a fibula bone into the leg. So again, these are things that you see. Remember amputations in the adult world. It's the same as children. If we cut something off, they're still going to have pain in the toe, even though the toe's not there. That phantom pain, checking the stump, all those things that we do, we're still going to do for this child. Now, kids love competition, don't they? They like to be up and out, and they like to be moving, and they like to win. So again, every sport, the problem is those injuries that we worry about, right? One of our discussion questions talked about kids playing sports. One of the biggest things is making sure they have the proper equipment, proper safety equipment, whether it's helmets, whether it's knee pads, whether it's wrist restraints, whatever it is, make sure that they've got the proper equipment so they can have the best experiences. Overuse, these are your strain things like I was talking about, right? These are those people, children who just, they're in ballet, they're in sports, they're in gymnastics, whatever it is. These children just want to do well and they tend to overuse themselves. And what we call it is that repetitive loading, stress fractures that occur because of it. Now, here's that developmental hip dysplasia. I've mentioned it a couple times. So you can see a normal hip should be right in the socket. As we look at children, somewhere it's up here. You don't need to know the different names. You just need to know hip dysplasia, the hip on the femur socket is not in the hip bone. So the ball and socket aren't where it needs to be. Now, what would you see with this child? So at birth, you have a hip that's up here. So you can already see that leg is going to be shorter, okay? Now, you also, if you look at the buttocks, the gluteal folds, it's called, one's going to be higher than the other because this hip is up here. So my fold is here, but this one's down here on this side. We also will see a positive ortolani. It relocates a dislocated hip, and then positive Barlow, it dislocates it. So dislocate and relocates. This is that clicking that you hear. That is a DDH. So first thing one of the pediatrician does on an infant is take their little knees on their back, put them up to the chest and pull them out. And what they're doing by pulling the knees up and then putting them outwards is checking for those clicks, looking for a shorter leg, et cetera, et cetera. And if they do, remember, 2 to 3 weeks, they heal bones, right? Neonates. So you can see why early intervention, that's what's going to help this child, notifying and seeing that this kid has an abduction of the hip. So let's get that Pavlik harness on. And what does the Pavlik harness does? It abducts. It brings that hip up to where it needs to go. You need to know that term, abduction of the hip. As we get older, if it doesn't work, we also have that Bryant's traction that can work, or sometimes they go into spica casts. If that spica cast doesn't work, those tendons and everything are now so rigid and solid. Sometimes we have to go in and cut tendons in order to open it up. Osteotomies, tendinotomies, which means just stretching the areas that we can get the hip joint back to where it needs to go. Now, club feet. I've already mentioned this with the cast, right? This is the feet in, out, over, around. Doesn't matter. You don't need to know the names. You just need to know there's different ways. Club feet are not all like this. They're not all like this. They're not all like that. They're all different ways. You get the point. How do we treat club foot? Well, club foot, the feet aren't the way that they need to be. So this child's not going to walk unless we get the ankles and the feet the way that they should be. So there's something called a Ponseti method, and that's those casts down there. Okay? Now, remember, 2 to 3 weeks, these guys heal. So every week, they have to have a new cast placed on. And if you look at them from the left to the right, you can see how that cast has changed, and then it gets to the real foot the way it should be by the end. So every week, it has to be changed. That's how quickly they heal. As they get older, they do need to be followed up with a podiatrist, something about orthopedics with the feet, making sure that the feet are in the correct position. Do they need a special shoe as they start walking? Those things we need to look at. Now, I mentioned it briefly about a brittle bone, and this is osteogenesis imperfecta. You know, I've seen one in my whole career. And he was a little boy who was really scary because I didn't want to touch him or pick him up because I was afraid I'd break his bones. So we used to take and put him on a baby blanket One nurse would get on one side, I'd get on one, and we'd lift them up with the blanket, not underneath him, because I was afraid maybe my fingers, and that's how easily they could break. So you got to be careful that my fingers wouldn't crack a bone or something. We don't know why it is, what happens. It's for lifetime. There's no cure with it, but we basically all supportive, okay, with these children. I used to see these children in the hospital where I worked. Most of the time, they end up in wheelchairs. Our goal for these children is we know they're going to have progressive breaks of bone. We know eventually most of them are not going to be able to walk, but we want them in a position where they can still be placed in something that gives them mobility, whether a wheelchair or something. Again, they still need to get up, they still need to move. I mean, go into the cafeteria. You used to see some of these children, and they'd be on their wheelchairs and they'd have horns on them. They'd go and beep, beep to get out of your way because they're going to run you over. Mentally, they're fine, but their bodies aren't. Okay. Now, leg calf perth disease. This is something I think I had when I was older, because all of the symptoms sound good to me. What it was a pain in the hip where you started to limp. And it is something they call an aseptic necrosis of the femoral head. So, aseptic, no infection, necrosis, no blood supply. So now your femoral head is dying. So, what do we need to do for this? These are mostly males this happens to, but we're concerned and we need to get blood supply back to that femoral head so that we keep that leg, right? So, these children present. These are the ones that have a limp, especially when they've been in bed or they've been sitting a while. They get up and they're really difficulty getting up because of that stiffness in their hips, etc. We do the x-rays, we see like a fuzzy thing on them. And what do we do for these children? Well, we need to rest the hip. We need to protect it from going in there and mashing the hip thing. So these kids are on bed rest. They're at home. Many times, because of the severity, and you can see the hips, that little fuzzy thing on the top of those heads of the joint, that little whiteness there, that is the aseptic necrosis that's going on there. Pain medicine is NSAIDs. And basically, home therapy, many times they'll put them on Bucks traction at home. It relieves that pressure there, decreases the pain, and gives that hip a chance to heal. Now, let's go over 3 different spinal diseases. So, kyphosis is humpback. This is the upper spine. Older people, they bend over and they lean forward, right, as they get older. It's called kyphosis. Now, lordosis is where the lumbar spine, it turns in. So you sort of lean backwards type thing. We see this in one of the conditions that you're going to see in the neuromuscular called Duchenne muscular dystrophy. One of the biggest symptoms is lordosis. And you could see they're going to have crooked backs, bent over. We're going to see these things. And obese children have a harder time with lordosis. Now, scoliosis, the most tested of all of them, of course. Scoliosis is an S-shaped curvature of the spine where you're going to see it many times. We don't see this until that pre-adolescent growth spurt, where all of a sudden the spine looks crooked. You bend them over, the hip will come down, the arm will be hanging more on one side than the other side. They used to do these screenings at school, but again, if we're seeing problems, of course, we're sending them a referral to the doctors at this point. So you've got a child, pre-adolescent growth spurt, who's got an S-shaped curvature of the spine. There's 2 different ways to treat scoliosis. One is medically and the other is surgical. Now, When does it become surgical? When the spinal curve, they call these curves in degrees. Where that curve is more than 40 degrees, they need to do a surgical intervention. Most of the time, spinal fusion is one of the names, but Harrington rods, it seems to be one of the other ones. And what they do with Harrington rods is they put rods down the spinal column and they attach the spinal cord to it, trying to take this S-shaped curvature and make it as straight as they possibly can. So, surgical intervention, you've got rods in your back. Post-op care of a child with Harrington rods. This is your log rolling child. You're like fractured hips in adults, Harrington rods in children. We got to keep that pillow between the legs, one swift movement over that we can turn them. Now, medically, how do we treat them? Medical is just putting one of those braces on, and you can see they can be colored. I mean, that little girl has a nice little leopard print, or we can have just plain colors, and it should be over a t-shirt so that rubbing doesn't hurt them. You leave it on 23 hours a day. It has to stay on. You only take it off for 1 hour a day to bathe, change that t-shirt, and that's it. It must be on. And they'll get physical therapy in order to strengthen their back muscles. Now, osteomyelitis. This is something that can happen from a fracture, right? An open fracture, but it also can happen due to many different things. I think osteomyelitis, a lot of it I've seen barefoot kids, their toe, big toe a lot, where they stepped on something. Now the big toe is infected, has osteomyelitis. And what are you going to see? Well, usually the kid will start with complaining, if they're old enough, complaining of pain. It's going to hurt. It's going to get red, hot, swollen, and painful. If we let it keep continuing, because it's an infection, staph infection most likely, it's going to be showing it now with fever systemically, and now your white blood cells are going to go elevated too. So that's marked leukocytosis because there's an infection in there. So we do an x-ray, we find it, and how do you think we treat osteomyelitis? Long-term antibiotics. Now, let me tell you something about the long-term antibiotics for osteomyelitis. Usually this is a staph infection. The skin is staph on it. That's just the normal thing that we expect. What is the drug that we usually use for IV treatment of staph? It's what we call the big guns. Vancomycin. Vancomycin is an aminoglucoside. What do you remember about aminoglucosides? You've got to be careful with monitoring lab values, right? So you have to do peaks and troughs and look at kidney values, right? Because signs and symptoms, the effects of these aminoglucosides are hearing loss and kidney damage. So you're going to be monitoring long-term administration for those side effects. Again, they're a kid. You'll always think about an infection. You always think about nutrition, nutrition, nutrition. Any infection, bone infection, you need to have this child high in protein. It does help with healing, right? Healing, protein, yes. Adult, children, both. It doesn't matter. Ewing sarcoma is basically a tumor of any bone, anywhere. Ewing sarcoma, they do radiation, shrink it, chemo. If we can remove it, you have to take the whole bone. You can't take a piece. You have to take the whole bone because the bone has it in it. So sometimes we can take the whole bone and sometimes we cannot. Now, JIA, juvenile idiopathic arthritis, or rheumatoid arthritis was the old name, but we call it JIA now. How would you know a child is suffering of it? Well, as you all know, I've said it many times, I have rheumatoid arthritis of the adults. I got diagnosed, oh, I think it's about 16 years ago now. And it took about 12 years for them to figure out how to treat me. So, what are all the complaints? Well, this is the body attacks its own joints. So, you have joint swelling. If you let that swelling go on and don't say anything to the body's immune system that's attacking itself and destroying joints, it's going to continue. So you're going to have all of these deformed joints, fingers, legs, arms, doesn't matter. I mean, I've got maybe a slight little swelling on this little finger here, but not too bad, just a little. But most of all, I don't have all that disfigurement there, but yeah, I got swelling. In the mornings, I got to stand up and stand there for a second to be able to move, because again, I'll be waddling as I'm starting to walk. Absolutely normal. And yes, I've got a limp when I first get going. And once I get up and go, I'm all right. Then I can keep moving. But once I'm stretched out, the one symptoms that you all forget is uveitis. And that's the picture of that eye. It's the redness of the eye that can occur with JIA, which means that this child must be seen and followed up with ophthalmology. So, diagnosis. Now, this is where I had the hard time. Nobody believed me. Nobody could say it was JIA, JRA, whatever the name is. They're, oh, you're fibromyalgia. And I'm like, no, I'm not. You need to listen to me. They have been trying for years to determine certain lab examinations that can say, yes, this is rheumatoid arthritis. Up to this point, they have all of the inflammatory factors, SED rates, C-reactive protein, ANA, rheumatoid factors, all of those things can show elevated. There's a new one. It's not written here. And it's the one that finally, when I said, all right, let's try this one, it came out. Usually they say the normal level is less than 50. My result was greater than 250. And they finally said, oh, yeah, you do have rheumatoid arthritis. And finally started treating me with biologics. And it took 6 or 7 different ones in order to find one that worked, that didn't react with me. I mean, I've gotten psoriasis from doing some of these biologics, Remicade, one of the most famous ones. But again, it's a very difficult diagnosis, especially for children. So now you've been diagnosed. What do we need to do? Well, the goal in JIA, of course, is to preserve function, prevent deformities, and relieve the symptoms, which is mostly pain. And how do we do that? Well, NSAIDs are the drug of choice, and then we need exercise of some sort. Now, I cannot walk. It hurts too much. Give me a big swimming pool, I'll be there for 8 hours. Doesn't matter. I won't get out. But again, finding something that child likes to keep that body moving. Do they like ballet? Do they like tap? Do they like gymnastics? Doesn't matter. Whatever they like, getting them in there and making them move. We use steroids for those big flares that we can do, but usually it's maintained on some sort of biologic and methotrexate, okay? One of the biggest ones that we see is Humira. I think that's the big one that we see of RA or JIA. So physical therapy, occupational therapy, relieves the pain. And again, heat, exercise. Now, do not give me heat. I want an ice bag. I want an ice bath. Heat makes me worse. Again, ask the child. Do you like heat or do you like cold? They're both just the same. Depends on what that person likes. And swimming, thank goodness, is a great exercise for JIA. And that child really needs good support, because this means maybe monthly injections or weekly injections, or this means a lot of compliance. Now, the other side of JIA is lupus. Now, JIA is all your joints, and lupus is my body's attacking all my organs. More common in girls. We know stress and all those things, any autoimmune, immunosuppressed disease, all those things can cause that to feel bad. With lupus, it's that cutaneous lesions, it's that butterfly rash, right? I put this picture up. There's many different ways it could look. It could just be flat, or it could be looking sparkled like that, little speckled sort of rash, anything on the face. That is lupus, okay? Usually they come in and what they're starting to complain of is that forgetfulness. It could get to the point of seizures. And then they bring them in, find out what's going on with the children. Now, problem is it can affect any body system. So we'll be monitoring lungs and heart, and we'll be monitoring those kidneys, and we'll be looking for protein also with these. Big thing with lupus is to be careful in the sun, believe it or not. Sun can cause big stresses with it. And again, these kids will be on steroids, they'll be on NSAIDs. Sometimes there's other medications they use depending on the child. So, Kirsten, he's 10 years old, sustained a fracture in the epiphyseal plate of her right fibula when she fell out of the tree. When discussing this injury with her parents, the nurse should consider that what? Which one?
C.
It's what we call the growth plates. Yes, we really concerned about growth and the way that bone is growing. All right, let's go to our first cahoots. Who wants to win? So do we have Adair's class winning, or is it Bogart's class going to win? Or one of each? One of each. We have no favorites. We'll go for both. You all know me well enough. I don't have favorites. Everybody wins. So muscular skeletal. Now, for Professor Adair's class, I do not look at who got what right, who got what wrong. This is not something I do for me to grade you or look at. This is your immediate test. Do you understand the concepts? So don't be afraid to put your name there. I'm not looking. Doesn't matter to me. This is here for you. Okay? I mean, some of you are like, oh my gosh, you can see my name and I got 16 out of 20 wrong. No, that doesn't matter. You got 16 out of 20 wrong. Now you've written that concept somewhere. You can go look at it, say, I don't get that. Let me read some more about it. That's what this is for. Okay, let's get going. Kahoot! Muscular skeletal dysfunction. What is the priority for a nurse to assess following a cast application? So I put a cast on a child. What are you going to be checking? Are we doing a rice? Or are we doing 6 peas? Those two things you need to know. We're checking everything. It's all the P's. It's paralysis and paresthesia, movement sensation, pulses and pain. Yes, 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 and yes. A multi. Patient teaching for a child with a fractured bone that has had a new cast applied. So when you take that little cool hair dryer, I mean, they want to do everything to get inside and they want to itch it. And you don't realize this. When you put a cast on, it turns warm. And you've got a fracture which don't like warm. So that cool hair dryer, and of course ice on top of the cast, yes, does really help. All right. Never powder, never a lotion, never a hanger, and never swimming. I'll tell you a story what happened about one little child. Little boy came in, he was like 6 or 7, got a cast on his arm, went home, jumped into the pool. Mom brought him back, and we changed the cast. The next day, the kid did it again, jumped in the pool and had to come back. So I had to sit down with this child and make him realize if you do it, you're going to have to come back into this ER all the time. As much as I really like you, I don't want to see you again. And your mom has more things to do than bringing you here. So once we explained that, and I gave him 3 different stickers, okay, don't come back. You got your stickers. And again, teaching younger kids about things like wet. What should the nurse monitor after a soft tissue injury? Soft tissue injury could be just an abrasion. It could be a huge ecchymotic area or small. But what are you going to be looking for? What are you concerned? I mean, I see a bruise on the outside, but I don't know how deep that goes, do I? So whenever you're looking at a soft tissue injury, always distally. So if it's in the arm, you're going to check the hand. If it's in the leg, you're going to check the feet. We're going to check distally neurovascular signs, making sure blood is still flowing. And we're going to document it. A fracture that penetrates the skin is called. So compound or open is called that penetrates the skin. What's priority on any care of a child that has a penetrating bone out of the skin? Priority care. It's infection, isn't it? It's antibiotics. That's your big, big thing with any penetration. Skin out, worry. Staff's there. Bryant's traction, what's that one? Bryant's traction is used after we've tried a spica cast, maybe after we tried Pavlik harness. We still got that hip, still not where we want it to go. So we put him in Bryant's traction. It is for children less than 30 pounds. It's for that DDH, developmental dislocated hip. The hips are elevated at a right angle, but the butt is off the bed. Okay. And yes, with any traction, you always check for skin breakdown, whether it's Pavlik, Bryant's, Bucks, don't matter. Check for skin breakdown. What is the priority nursing care of a child with a compound fracture? And it doesn't have to be an arm, a leg. It can be a finger or a toe. They're just as important. And priority compound or open fracture is the IV antibiotics. What is priority nursing care for a child who fell off a second floor balcony? So you get a child who's fallen off of something, and I've seen actually 3 kids in my career in 10 years, 3 kids falling off a second floor balcony. I've seen 3 different outcomes. One not good, one surgery, long-term recovery, and one that I don't even know how they jumped off and there was barely anything that happened to them. So again, our concern with any child that you're concerned about a neck injury is to immobilize it. You heard me talked about that little 15-year-old boy that had the angulated C5, C6 fracture because he was immediately put into immobilization at the scene. I was the primary trauma nurse on. The neck was mine. Nobody moved that kid without me. And as I said, thank goodness, because of great nursing care and, of course, medical care, this child is perfectly fine today. And he could have been paralyzed from the waist down. He could have been. Easy. Principles of managing soft tissue injury include soft tissue injury, sprain, strain. So again, soft tissue injury, rest, ice, compression, elevate. Absolutely. Sit them down. Let's put ice on it, constrict it, put an ACE on it, elevate it to decrease the swelling. Apesial plate fractures in children may what? So apesial plate fractures are all about the growth. So if we do not have them completely correctly aligned, they're going to have a crooked arm, a leg, a finger, a toe, or it could be shorter, and we don't want that. So if we fix it properly, open reduction, internal fixation, that we should have a straight whatever body part it is. What findings for a patient in skeletal traction indicate peripheral neurovascular impairment? So, peripheral neurovascular impairment, I don't have a pulse. Or I'm going to see what? Prolonged capillary refill. I'm going to see the color is turning pale, paresthesia, paralysis. All of these things are going to tell you something's going on there, but absolutely a pulse. A multi. How should the nurse care for the skeletal traction for a child with a fractured femur? So you got this child on Bucks traction. How are you going to treat them? So the one thing that we do with any sort of traction that has a weight on it, you always document the weight. That's showing you if it's supposed to be 5 pounds that you've documented. Yes, I've checked. Yes, it's 5 pounds. Anybody can walk in a room and take a weight away. So that's why you do it. Also, make sure it's weighing there, it's weighing freely. We never ever take it off. We never reduce unless a doctor orders it. We just document the weight and that keep them free flowing, that they're just hanging there and making sure they're pulling it well, checking neurovascular signs on that leg. When caring for a 9-year-old in Buck's traction, what action by the nurse is correct? So when we are caring for a patient in Buck's traction, we know that there's something, a fractured something that we're trying to stretch out, and we know we're always worried about neurovascular signs. So what are we checking? Capillary refills on the extremities every 4 hours or more often if we need it. Very good. What position do you put the legs of an infant with hip dysplasia? What did I tell you? We put it in abduction. Abduction. Okay, that puts that hip joint back into the joint. You need to know that name. Abduction with a B, like Bogart. What statement by parents indicate more teaching regarding their 2-year-old infant with club foot? What is wrong here? They need more teaching. They know all of it except. It's another pair of club feet. You can see they're all different. Again, children with club feet need to come in every week for replacement of their cast. And the reason is like I've showed you, when we're talking infants, neonates, the first 28 days of life, they can heal a fracture in 2 to 3 weeks. So if we do early intervention, get them into casting, we can straighten out these ankles and feet quicker. Okay, so as soon as we can. And remember, they're going to require follow up as they get older to make sure their feet and ankles are in the right positions. They don't need some sort of special shoes. A multi. Osteogenesis imperfecta. I was watching a documentary on a child with osteogenesis imperfecta, and it was a very hard thing to diagnose this child. And these parents were charged with abuse because a kid had osteogenesis imperfecta. And then finally, they figured out that this was the diagnosis. And of course, they had all these pardons and excuse me and I'm sorry type things. But this is a child who is suffering with OI, and these parents were being accused of abuse. So it's something that can happen, just to let you know if you ever see it. It is brittle bones. It is everything is crooked in these bones because of the way that they're done. And again, our goal with osteogenesis imperfecta is to try to keep them in a position where they can be mobile, whether in a wheelchair, something, a wagon, something. Let's get them mobile to keep them out. We don't want them being depressed and alone by themselves because they can't move. What is the pathologic cause of leg calf perth disease? See that fuzzy stuff on that left hip there? It's on the right side. You see that fuzziness? That's leg calf perth. So, leg calf perth, it's an ischemic aseptic necrosis, which means it's not an infection. All of a sudden, blood supply don't go there. We don't know why. And that's what leg calf perth disease is. Treatment, bed rest, good diet, high protein, maybe buckstraction, right? NSAIDs for pain. Kyphosis. What's that? So kyphosis is the upper back. That's the humpback. A multi. Which assessment indicates an infant has developmental dysplasia of the hip? What would you see? So, developmental hip dysplasia, you're going to see those asymmetrical leg folds. One's going to be higher than the other, or gluteal folds. One leg is going to be shorter than the other. Positive Orlani, you're going to hear these clicking going on. We know Moro is a startle reflex, and we know Babinski is the bottom of the feet. We all have it, all age people. Lordosis is described as And it's that lumbar spine. It sort of goes in. They sort of lean backwards as they walk. And as I said, Duchenne muscular dystrophy. We'll go into it. I'll show it to you. Scoliosis is. Scoliosis is an S-shaped curvature. Again, this is very, very evident usually at that pre-adolescent growth spurt. All of a sudden, we're going to see that curve be more exaggerated. Adolescents with scoliosis that have up to a 45% curvature of the spine would need to. Now, you're going to see different things between 40 to 50. Which one does what? Up to 45, and then after 45, what would you do? So, up to 45%, you're going to wear the brace. After that, you're going to need surgery. And it's between 40, 45, you're going to see different. It depends on actually, again, the physician and the facility, but usually about 45, absolutely, we're going to need a brace. After that, we'll need surgery. A multi. Teaching for a child with scoliosis with less than a 40-degree curvature. So you can wear that brace 23 hours a day. We only take it off to change our cotton t-shirt underneath because that's the sweat and prevent rubbing there, and to take a shower. That's it. And then no lotion, no powder, no nothing underneath it. And it's all about physical therapy, strengthening the back and the muscles so that we can have a straighter spine. A multi. A Pavlik harness. So it's used for those infants that have that hip dysplasia. Yes, you're definitely going to check the skin, and you're also going to massage underneath that. Now, that doesn't mean you're going to be lotioning it and leave lotion there, but you need to make sure the areas are not reddened so you can increase the blood flow. That's what that means. And then, of course, it holds the hips in abduction. Abduction is what we want to know. Very good. What is osteomyelitis? So osteomyelitis, itis means inflammation or infection. It's an inflammation of the bone, osteo. Very good. Goals for juvenile idiopathic arthritis includes, well, what is GIA? It's the body. And what does the body do? It says, I don't like your joints. I'm going to eat you up. I'm going to take care of you. So our goals, we just want to make sure that we reduce that joint pain and swelling. You reduce that joint pain and swelling, that child be up and moving better than it can, because it can get to the point where it hurts and they can't even move. So again, let's keep that pain down, the swelling down. Let a kid be a kid. What priority action should a nurse take to a patient with a suspected spinal cord injury? What's our goal with a spinal cord injury? We don't want them to have any further damage, right? So how do we do that? It's all about immobilizing that spine. You can do all the neuro assessments you want, but if you don't immobilize that spine, all of a sudden that child becomes paralyzed from the waist down or even from the nipples down. So again, first of all, let's take care of that spine and then we could do the rest of the assessment. And last question. Most common causes of spinal cord injuries are and it's all about motor vehicles. You're always going to see that is the highest injury for all age children, okay? And of course, sports will be the part of it. Very good. All right, let's see how we did today on this one. Susan, good job, Susan. And a Natalie, good job, Natalie. Whoop, whoop. Number one, Steven. Good job, guys. I'm proud of you. And a Fee and a KJ. All right, let's go on for the rest of our PowerPoint. I mean, y'all don't know me, but I will get you out early because we don't take a break. So that's why I go straight through and get you out of here early. All right. So let's go into
Bogart, I don't know
that.
if you seen my message at the beginning there, but I can't access the PowerPoint, and somebody else said they couldn't either, just so you know.
Okay, I will be reattaching that when I put up your recording today, so you'll get it again.
Okay,
Thank you for
thank
letting
you.
me know. No, thank you for letting me know. If you don't tell me, I don't know. So I appreciate it. And I think, if you tell me something, not only you get it, I do it for the class. Because I know if one person can't, I know the whole class. So I appreciate anybody telling me anything. Thank you. Thank you. Appreciate that. All right. Neuromuscular, muscular dysfunction. So when we think of that, number one, what do we think of? We think of cerebral palsy. These children, you wonder how much they have in their brain, how much do they think, how much do they know, but how can they express themselves? Because what this is, it's a abnormal muscle tone and coordination. They can't chew right, they can't move right, they can't walk right, they can't anything. Their motors just doesn't work the way that they should. Most common permanent physical disability. So, why? What causes cerebral palsy? Well, I think that it could be something in the brain that wasn't right, could be a vascular occlusion or a hypoxic moment, laminar degeneration, which has to do with spinal cord and that. Low birth weight. Why would low birth weight cause cerebral palsy? Well, when a baby is born, like that bottom left-hand picture, there's probably about a 600-gram baby there. Those brains are so fragile and their vessels are so fragile that they get multitudes of intraventricular hemorrhages, which causes delays in many children and can cause cerebral palsy due to low birth weight or due to hypoxic anoxic episode. That's where I've seen a lot of cerebral palsy that maybe they wouldn't have had at that point. It's that hypoxic anoxic episode, and it could be combined with that low birth weight. So, children with cerebral palsy, diagnosing them. So, all premature infants that go through a newborn ICU are usually followed very closely with their neonatologist. They usually call in all sorts of therapies in order to help these children get to where they need to be. I mean, if you're born at 24 weeks, in 3 months, you're just born and you've been outside for 3 months already. So, are you where you need to be? I don't know. This is something that can cause, increased occupational, physical therapy, speech therapy for these children. So, cerebral palsy. Spastic cerebral palsy is usually what I think of when I think of cerebral palsy. I had a little kid at where I used to do clinicals, little Jonathan. He was, 7 years old. nonverbal cerebral palsy child who, when he used to see me, the smile would go ear to ear, but he was so spastic, his arms, and he would, because he knew I was going to come up, give him a big hug and a kiss. So was he alert? Yeah, I think so. Could he express it? No, not really, because he didn't know how, because of the specificity of who he was. Okay. I never, ever think that just because they have cerebral palsy, they don't have a brain, because many of them have more than you can imagine. So, cerebral palsy, you're going to see a child who is gross motor development. Little Jonathan had to be in a wheelchair. He couldn't even get up on a walker. Although there was other children with cerebral palsy that were up on walkers that were less. Remember, there's all different types from mild to severe, all right? There is abnormal muscle performance, muscle tone, postures, etc. You've got to be careful with any child with things that affect muscles. You got to think about eating and choking and giving them time to eat because their muscles don't work like me or you. Can they chew and swallow as they get older? Okay. One of the things that I could see, these children, as I said, they're not all like you think cerebral palsy, their brains aren't there. Many of them have cognition and they're aware of their surroundings. So let's give them that ability to be able to get around. I mean, if you look at that picture, that kid has splints on, special shoes, looks like he could be a cerebral palsy or someone with limited emotion, right? But we gave him something that he can get around with. Now, that supports independence, and it's what we want to do for that child, okay? Also, this little 6, 7 year old boy that I took care of, Jonathan, I went over and watched what they did in speech therapy, and I was actually surprised. This child couldn't speak, but he had a pad, his own little iPad, and he could push on it things that he wanted to tell the therapist what they were doing. They were doing shapes, ovals, circles, triangles, rectangles, and colors, and he was pushing the correct ones. So don't think that these kids aren't there because many a times they really are. And what we need to do with any child, any delayed child, we need to put them, where they're going to get the best education they can. Many of these children, not necessarily the nonverbal, but mild cerebral palsy, could possibly put in regular classrooms because that makes them want to learn. It gives them the information they need to know, and it gives them that socialization they need. So, because of those irregular, stiff type of spastic movements, many times they have ankle foot brace. Sometimes they get surgeries to release the tendons that are oh so spastic. Again, pharmacological agents, botulism, right? We're going to put in Botox, and that actually relieves that muscle thing. Another thing we don't think of with cerebral palsy is many of them have seizures. Part of it is seizure disorder. One of the medicines is for seizures is phenytoin. Remember, phenytoin dilantin causes gingival hyperplasia. So dental hygiene, so important on these children, okay? And again, we need to exercise them with the experts, physical, occupational therapy, and speech therapy to work on their eating and their talking if they can. So prognosis, well, 85% can really achieve ambulation. I know that with Jonathan, they kept re-upping what his goals were they're going to do because he kept meeting his goals. He knew his colors, he knew his shapes. Now keep going up, and then it's also in their physical form too. What can they do? And keep making them, push them to do more and more and more. That's what OT, PT, speech therapy does. Now, parents. Parent needs to know what's going on when they're getting all of this treatment, and they need some equipment home to help them because usually these facilities are Monday through Friday. So on the weekend, these children are at home. So they need equipment at home to help them. They need to know how to give medications. always number one is safety, safety, putting, seat belts on these children, strapping them in. Very important that we tend to forget those things. Those are the most important things. As I said, it's always going to be physical, speech, occupational therapy, and again, support the family. If they're doing a good job, let them know, hey, he's doing this. You did a great job. Now, neural tube deficits. This is that spina bifida. That's that cast that we saw earlier. Now, you don't need to know all the different names, okay? But what you need to know is sometimes the spinal cord doesn't get born inside the body. Sometimes it's born on the outside. The one that we talk about is spina bifida or meningocele or myelomeningocele. Their spinal cord is born outside of the body. So it pulls from the bottom nerves, pulls out, and pulls that spinal cord out. So the lower extremities have a big chance for diminished nerves, as in movement, stools, and urine output. You got to be careful with those three things because there's diminished nerves there. They don't have what me and you have. They have diminished. The nerves have been ripped. They're not going to remake themselves. They're still going to be deficient. Now, neural tube deficits can be helped if we take our folic acid. This is the one in pharmacology. They're saying folic acid you need to take 3 to 4 weeks before you have a baby because it helps decrease neural tube deficits. Well, that's your neural tube deficit they were talking about. Besides neurotube, the folic acid, there's also low B12s, diabetes, and more of an obese mom. Those are your factors that can increase your risk. So you got a baby who's born and he has this thing on his back, this myelomeningocele. What is your job? Well, again, your insides are born on the outside. So, infection control, right? We need antibiotics prophylactically. Absolutely. Also, that thing is from the inside, is on the outside. We need to keep it moist but sterile. So, we need 0.9 normal saline and a sterile dressing. We also need to maintain the skin integrity so that once we can get that spinal cord pushed back in, we can close the skin and the tissue's good skin to close up or it will dehisce. So we need to make sure of skin integrity. As I said, we are concerned about lower leg strength or weakness. So we need to follow up with any orthopedics. Do we need braces? Do we need PT? What do we need? Or is this kid not going to move his legs at all? Do we need a wheelchair? What do we need? Also, we need to be concerned about monitoring bowels because they don't have nerves there. Maybe they're going to be constipated, so you have to watch that. And also urine. Many neural tube deficits end up requiring to be having a Foley catheter every 4 hours, a straight cath, because they do not have any urge to go to the bathroom. So they are catheters every 4 hours. So latex allergy all over the place because of the amount of latex that they'll be subject to if we don't do it, and they can become latex allergy. I'm latex allergy because of the amount of gloves that I took on my hands as a newborn ICU nurse. And those gloves just ate into my hands and I became a latex allergy. Again, it shows you how just constant being touching those things can cause it. As I said, neurotubes, we take the folic acid, as I said. Now, spinal muscular atrophy type 1. Thank goodness there's not many of these things. These children are born, and this would be a kid who never lifts his head up, never rolls over. It's called a floppy infant syndrome. But even what they're born with, it still becomes even less in their with skeletal wasting. They usually you'll see them get really to the point where they can't even breathe, and they usually die by the age of 2. And that is called Werding-Hoffmann disease. It's not a great disease to think of. It's not much outcome to that. Now, another neuromuscular disease is called Duchenne muscular dystrophy. This is the most tested neuromuscular disease on HESIs, NCLEX, and everything. So you need to know what a Duchenne muscular dystrophy is. Well, it's called a pseudohypertrophic muscular dystrophy. Most severe and most common, and mommy, X-linked, gives it to males. Males are usually aged 3 to 7 that we see it. So this child, this boy, is usually up and walking, but we might see big hypertrophic calf muscles. Like unusually, you'll see big muscles in the calves. And then about age 3, they're going to be starting to fall down and they're going to go backwards in progression. They're not going to be able to run, be able to walk, and we're going to see things going on. It is progressive, generalized weakness. Now, how do we treat this? Well, we need to keep the muscles moving. So we are going to have them in physical therapy, occupational therapy, and speech therapy for eating because muscles there get affected too. Usually, by their adolescence, the muscles of the heart give out, or the diaphragm give out, and they usually die from respiratory or cardiac failure. Now, Duchenne muscular dystrophy. The kid, we just see these hypertrophic muscles. We see that all of a sudden they're falling and they're starting to show weakness. So we need to figure out, how do we test for this? Well, diagnosis is usually done by, number one, that assessment, that mom telling you that they were walking and now they're not. That physical assessment, seeing hypertrophic muscles, could be in the arms and it could be in the calves too. These are things that we'll see. So we need to test muscle strength. And we can test muscle strength with a test called an electromyography or an EMG. They used to do these things for like cervical neck damage, where they test the arms to see if the muscles are working and nerves are working. Well, they do this also for children. And what they're monitoring is if they put an impulse to this machine and the body responds to it with a muscle contraction. This machine will tell you if the muscles are responding or if they're delayed. When they do this test, it is like this kid has been in a marathon. We have spasm muscles all over the place. So when they come back to the floor, they're going to hurt. Like they have been at the gym for the first time in 28 years. Like, what do I think I was doing? My muscles hurt everywhere. Same thing these kids are going to feel. So give them some acetaminophen or ibuprofen and tell the parents it is temporary. It's just because we were looking at muscles to see if they're working. So we worked muscles that haven't been worked in a while. Okay. These children do have mental impairment. They're cognitively, they are delayed. And because of the muscles, they're not moving as much. They tend to be obese. So there really is no treatment because there's no cure. So what do we try to do? Well, we try to keep the muscles moving. We try to keep that child active. And if that parent wants to have another child, we need genetic counseling because the mother still has that X related gene that causes Duchenne. Does she want to try again? Because another male could probably produce another Duchenne muscular dystrophy child. Now, another neuromuscular disorder, mostly we see it in adults. I actually saw it with one of the supervisors I worked with. She was 28 years old. She had an upper respiratory infection, and all of a sudden she was weak and falling down. And we admitted her into our ICU at her hospital where she worked, and they found out she was Guillain-Barré. Guillain-Barré is an interesting diagnosis. And All of a sudden, it starts with the feet. Okay, your feet all of a sudden becomes numb and you start tripping and waddling and walking funny. Then the nerves go upwards, ascending to the middle of the body. So then all of a sudden you might be incontinent or you might be constipated and you can't push it out, things that aren't usual. Now, what's the next nerve up that it can hit? It is the phrenic nerve. What does the phrenic nerve do? It makes the diaphragm breathe so that you can breathe. So, our biggest concern with Guillain-Barré as it progresses, O2 saturations, monitor them because we're going to stop breathing. These, if you can imagine, in pharmacology, you learned about neuromuscular blockers, right? That paralyze you from head to toe, but you're alert. This is what happens with Guillain-Barré. They're wide awake. They are alert, but their body does not move at all. I can't imagine how scary this would be. Yes, they're going to get medicine for that. Now, when do we what do we do for this? Well, as I said, I went all over all the symptoms and what you see, et cetera, et cetera. Now, treatment for this is yes, it's going to be all symptomatic. Yes, you're going to be watching all of that type of O2 sats, making sure it's going. Now, we can give steroids, it might work. IVIG, plasmapheresis, it may not, or sometimes it just takes time. They really don't know. But again, any medicines to prevent complications, well, they get heparin for possible DVTs, maybe, or Lovenox, maybe. But again, it's the treatment, we're not sure. Now, we've gone from our feet up to our phrenic nerve, and now we're not breathing. And now this child or adult, whatever it is, all of a sudden you're going to see their ventilator. They're starting to take a breath on their own because it starts from up here now and goes down to the feet. When you start seeing that patient starting to take a breath, their phrenic nerve is coming back. And you're going to see now that paralysis go down to the feet and go completely away. Depending on how long they were paralyzed, they might need physical therapy to strengthen them in the end, but they can turn around and do very well. Interesting diagnosis. Tetanus. We thought tetanus was gone, but no, we still can. This is for that patient. Let's say they stepped on that rusty nail, right? And they didn't go get treatment. What would you see? Well, tetanus is all about the upper airway getting swollen, lockjaw, and everything's swollen and I can't breathe. So it is fatal if we don't take care of it. Neck, muscle rigidity involving the masseter neck muscles. And I just choke myself and I can't breathe. Treatment. Well, what we're going to see is, yes, all the muscles are going to go away. Again, this is all neuromuscular. Tetanus hits from the brain down and all the movement that are going onto it. These are things that we're going to see with these children, even adults. So we treat it with tetanus vaccine, tetanus toxoid. We're going to be giving the tetanus vaccine, and we're also going to inject around that area a tetanus toxoid, but we're also going to clean whatever what that puncture was. Was it on the toe? Was it on the hand? Was it on the buttocks, on the leg? Just clean it, soap and water, and put an antibiotic ointment on it. And that's the way that we would treat those things. Usually, you're going to see all of a sudden they turn around with a tetanus toxoid or antitoxin after that exposure. So these kids, they're going to stop breathing on us, right? So we're going to have them in there for respiratory support. We're going to, because of that crunching on the neck, they can't breathe. So what do you do for an immobilized child? Fluid electrolyte balance, making sure they're okay. We're going to be giving their meds, that immune globulin therapy, whatever it is. And of course, cleaning that wound. And this is severe muscle spasm, choking yourselves. You want those muscles relaxed. So we put that patient on a muscle relaxant. This is what we'd use to go to surgery, Pavulon. This is something we would use to knock you out, to intubate you. This is something where you're awake, but your body's gone. This is one of them. Now, botulism. Yeah, we look up botulism. I live in South Florida. And one of the things I've heard some of the parents tell me, I have a baby who suffers from constipation. So I give him a little bit of Caro syrup, like my grandma told me to do, and that helps them move their bowels. I warn them that honey or this light or dark corn syrup, Caro syrup, can have colostrum botulism in it, and it can cause a really bad effect on your child. Again, what happens? It is progressive, life threatening respiratory. Again, it starts in the head, it works down. It's usually within 12 to 36 hours after that ingestion of it. And same sort of treatment as tetanus. We want to give that immune globulin of that botulism, make sure that we do okay. Always, if it's respiratory, we'll support respiratory. We will always, in children and adults, make sure nutritionally they're getting what they need. Whether it's tube feeding, it's hyperlipids, whatever it is, we're going to do that. And we will wait until that child comes back. You continue. And then spinal cord injuries. This is my little guy that his story was one Saturday afternoon, and I get a call. I'm primary trauma nurse on, which means I'm in charge. I have to do all the documentation. I got to make sure everybody's there, make sure that child gets everything they need. I'm in charge. So we get this call. 15-year-old was playing baseball. His head hit the knee going into third base, and the stands heard a crack. Immediately, his right leg was numb. His left leg was a little bit paralyzed. Somebody at the scene knew not to move the child. They were able to get that kid, rescue a helicopter, get the kid, copter him into my hospital, brought him down to my trauma room. My priority was always his neck. So, but first of all, let me calm him down. He is already strapped to a backboard. His neck is already secure. This kid is freaking out. He's 15 years old. So me and him had long talks, and I told him what I'd do for him. Anything I did, anything everybody was doing, I would let them know. I took him to an MRI that day. We never do MRIs in the ER because they take a long time. Usually they're not necessary. This kid had an angulated, worse than that picture there, angulated fracture. And we took him to MRI. I had to move him off of a stretcher onto the MRI bed. I took the head and neck. And you're not moving unless I tell you to. And we did on my movement. Yes, I can be somewhat tough, but when it comes to my patients, they're always number one. I'm not there to take care of anybody's feelings. I want my patient safe. I want no further injury. And I told everybody that. So we're moving on my command. And we did. We got the MRI done, got him back on. I got him up to the ICU after that. We put tongs in his head, and none of it we increased that injury at all. The next day, Monday, he went to surgery and they did a fix. And as I said, 2 weeks later, I went to visit him upstairs. His left leg was completely back. The right leg had some slight numbness, and he was ready to go to rehab for that extra strengthening. And as I told you, 1 year later, this kid came in to give me a hug to tell me thank you, that he remembered me and he wanted me to know that I helped him through it. So again, you think you're nothing? Yes, you are. You're a lot. So, management of spinal cord injuries. Number one, stabilization. Again, priority. So, a progressive infantile spinal muscular atrophy and the most common paralytic form of floppy infant syndrome is which one? Do you remember? It's Wording Hoffman.
Is it D?
Wording Hoffman's. It is C. All right, let's go now to our, I don't care if you guess and you're wrong, you tried. That's all that matters to me. There's no right or wrong. It's the trying that I like. All right, let's go to There's only 20 questions here, and then we'll be done for our day. We didn't do bad at all with time.
Professor Bogart, will you be sending in also to this recording to
I'll be
Professor
sending
Adair's
you
class?
I'll send everything to this class, both classes. You're going to get recording, you're going to get the Kahoots, you're going to get the PowerPoint. Whatever else you need, let me know and I'll send it to you. Not a
Thank
problem.
you.
I,
Thank
I
you.
take care of you guys. You should know that by now. Anybody who asks for help, you get help.
Well, in that
You
case,
really
then can
do.
we
I
get all the
appreciate
answers
you.
1 through 50? Then you said anything.
Oh, 1 through 50 answers. You have them in the Kahoots and in the study guide. You got all the answers. Okay, Latasha? That's okay. I like a woman who speaks up for themselves. Nope, you're not getting that. You have everything there. I make sure you have everything you need. You have just got to put the time in. I put the time in to make this stuff. A lot of time. Okay? I'm not asking you for something that I've not done myself. So who wants to win this one? Steven, you going to win again? Susan? Anybody else coming? All right, let's just get going. Neuromuscular. Goals for juvenile idiopathic arthritis includes so the whole goal with JIA is to reduce that joint pain and the swelling. Because once there's swelling and then the joints hurt, I'm telling you, pain is horrible. And when it hurts, you don't want to move, you don't want to do much of anything. So we don't want to do that to our kids. A multi. What might you anticipate for a child diagnosed with JIA? What would you see? So they come in to the doctor, urgent care, or wherever, and they say, I don't know what's going on with my kid. What would you see with a kid with JIA? Well, we're going to see that joint disfigurement. I mean, it might be as little as my little finger, or maybe not. But you're going to see that difficulty walking, especially when they've been sitting for a while. Okay, that stiffness. And remember that red eye, uveitis, okay, can cause some swelling in there. So we don't want to lose sight. And remember, facial rash is lupus. It is not JIA. What is cerebral palsy? So, cerebral palsy is when the body and the movement and coordination just doesn't do what it's supposed to do. I mean, I think the most one that we think of with cerebral palsy is that spastic cerebral palsy where they try to do something and they get so tense and they just shake and their muscles get so tight. And that is that spastic cerebral palsy. A multi. What are signs and symptoms of spastic cerebral palsy? So, when we talk about cerebral palsy, we talk about a child that can't control their muscles well. So, there is poor posture, poor gross motor, poor fine motor. And as I said, that hypertonicity where your muscles are so tight is too tense. And then, of course, poor balance because we can't manage our muscles and we do have trouble standing up. They might need a walker or a cane or something to help them, or a wheelchair in some of them. A multi. When feeding a child with cerebral palsy, what is important to remember? Cerebral palsy is a problem with muscle coordination, right? So what would you be concerned about? That's how you have to look at these questions. So remember, if we're feeding a child with problems with muscle coordination, we're worried about choking, safety, choking, right? So head of the bed elevated. You've got to give that kid time to chew and to swallow. They're going to take longer. You would actually thicken the liquids. They do better with thick stuff. And you don't have to just feed with gastrostomy tube. Many of them will eat by mouth as much as they can. And if they can't eat a lot, they'll put the rest in the gastrostomy tube, but it's not only. They need, if they can, they need that, putting it in their mouth. They need that. A myelomeningocele. So a myelomeningocele is basically a hernia of the spinal cord and the meninges. As I said, it's usually in the lower back at the lumbar area, and the nerves and the meninges pull from the bottom up and come out. So we know those nerves have been ripped from the lower extremities. So all of our concerns in nursing care are about that decreased sensation on the lower extremities. A multi. What can help a child with lupus prevent exacerbations? So lupus, the sunlight does bother them. So wear sunscreen, decrease that exposure. The other thing with usually immunosuppressed children, especially with lupus, is again that prophylactic antibiotics or steroids before, like dental extractions and whatnot, to prevent problems. Okay, that'd be something you'd have to talk about with the doctor if they want to do prophylactic. Infants with a myelomeningocele demonstrate what? My meninges and spinal cord have been ripped up and out that lumbar spine area. What would they look like? So we know that their movement and the sensation in the lower extremities is going to be decreased at some point. Some are completely, they don't feel anything, and others, they do have feeling, but not complete. Myelomeningocele have decreased motor and sensations of the lower extremities. The nurse should monitor closely what? So the big thing that we're concerned about with that decreased sensation in the lower extremities is number one, urinary retention, and also the bowels. Are the bowels moving? Are they constipated? These need to be monitored and documented very closely because they can rupture their bladder, and if they're not moving their bowels, that can also be a problem too. Do we worry about skin breakdown? Not as much as the urine and in the stools. A key feature of Duchenne muscular dystrophy. So our big thing with Duchenne is that progressive muscle wastage. You'll see those big hypertrophic calves. All of a sudden they start falling down and waddling. And that is our first sign of, let's test them for the Duchenne muscular dystrophy, and we're going to be measuring muscle strength. So what is the one of the procedures that a child with possible Duchenne's may need to diagnose the condition? So Duchenne muscular dystrophy is a progressive muscle wasting. So we're going to be measuring muscles, which is electromyography. They can either take a needle, like an acupuncture type needle, or they could take a little skin tab, like you'd put EKG monitor on your arms at certain places. And this little machine will just put a little electrical impulse, and it will measure how quickly does the muscle react to that impulse. That's an EMG. How is Duchenne muscular dystrophy inherited? So Duchenne, it comes from mommy. It's an X-linked recessive pattern. Know that if you have a child with Duchenne muscular dystrophy, genetic testing is going to be paramount if they want to have another child. Mom, she carries this recessive gene that can cause any male to have Duchenne muscular dystrophy. And you don't see it at birth. It's usually after they up and they're walking, and all of a sudden you start seeing them falling down and you start seeing the delays starting to occur at that point. In caring for a patient with Guillain-Barré, the priority concern is so remember, Guillain-Barré is an ascending sort of nerves start to not work from the feet all the way up until it hits the phrenic nerve and the diaphragm. So our biggest concern, once we determine it's a Guillain-Barré, is to make sure that this child is breathing. So O2 sat monitor minimum on this child, and we have to make sure that they're breathing. If not, we need to maintain an airway. Many of them end up with a tracheostomy because they end up being intubated for well over 2 weeks. So it usually takes 2 to 4 weeks, many times, to reverse itself. For a patient suffering with Guillain-Barré, they complain of weakness that was what? So we call it ascending. And the reason is it starts with the feet. You start with a little tingling and numbness in the feet, and you start seeing stumbling and maybe falling. And then it goes upwards, and then you might see problems with urination, can't, or bowels that you're constipated. And then it goes up, ascends more, and then it hits your diaphragm. So knowing where it's going, how is it getting there? It is ascending. We know when the diaphragm is going to be hit. A multi. Treatment for Guillain-Barré include what? So Guillain-Barré, it's not something that's treated with an antibiotic. It's not bacterial. It's not an infection. It's something immune. So what we do is we're going to be given IVIG. Let's intravenous immunoglobulins. Let's boost this own patient's immune system. Will they be placed on heparin? It depends. I mean, it could be placed for DVTs or Lovenox, but the treatment for Guillain-Barré is IVIG and keep them breathing, respiratory support. It's not heparin for everybody, and antibiotics, absolutely not, because it is something that's immune, has nothing to do with an infection. What types of cerebral palsy causes hypertonicity and poor fine motor skills? So, type of cerebral palsy, hypertonicity, that's that spastic. That's when their arms get really tight. It's called spastic cerebral palsy. That was my little Jonathan. What priority action should a nurse take to a patient with a suspected spinal cord injury? So if you are worried about spinal cord injury, number one, immobilize the spine. Because if you don't immobilize it and then you tweak that spine more, they can become paralyzed from neck down, waist down, doesn't matter. It's something that could be prevented. So immobilization of the spine is always number one, and then you worry about everything else. You should get a tetanus shot every blank years. You know, when I first started nursing, it used to be every 2 years, and then it was every 5 years, and now it's every 10 years. And they're also doing the diphtheria with it too. That's part of the new tetanus shot. And last question, which is a symptom of tetanus? So tetanus is all about lockjaw, or the muscles, the masseter muscles all suck in and occlude the airway so you can't breathe. That is tetanus, yes. Number 3 is a WS. Good job. Number 2 is Natalie. Good job, Natalie. Number 1, drum roll. Stephen. Good job, Stephen. We have a KJ and we have a jaw. All right. So I've gone over everything I can for today. As I know, I'm going to be sending you everything off to everybody. You'll get the recording, you'll get the Kahoots, you'll get the PowerPoint. If you need anything else, just give me a message and I'll send it to you. It is not a problem. Remember, this week you still have a couple of things that are due. You have a case study, discussion question, and you do have a dosage calculation. You do have the form in the modules, or if you need another one, you can always ask me. I can always send it to you also. Anybody have any questions about anything?
Can you check my resubmission?
Yes, I can.
Thank you.
You're very welcome. Anybody else? Well, that's all I have for today, guys. Thank you very much. Have a good day.
You too.
Thank you.
You're
Bye.
welcome.
Are we still good to meet?
Yes, I'm going to
Okay,
sign
cool.
out and sign back in, Braden. Okay? Sign out, sign back in.
I was